Welcome to the very first Heart Cord Junction podcast. I'm Alex Samuels, a former clinical nurse consultant in the cardiac space. Specialist cardiac topics can seem very difficult for a lot of us to understand. So the aim of my podcast is to make specialist topics and health topics, cardiac topics, really simple to understand. And my very first guest today is Dr. Kevin Ning. He is a consultant cardiologist and electrophysiologist who specializes in sudden cardiac death prevention, heart failure management, and inherited cardiac diseases. His expertise also lies in atrial fibrillation, supraventricular tachycardia, ventricular tachycardia, and cardiac resynchronization therapy for heart failure management. Kevin's extensive background lies in a fellowship in Italy. He was also the cardiac director of electrophysiology and pacing at the Cairns Hospital and led the only arrhythmia service in far north Queensland. He was also the clinical lead for the region's heart failure service. He also pioneered the only cardiac genomics clinic in the state specializing in the treatment of inherited cardiac diseases. Please welcome Dr. Kevin Ning. So welcome, Kevin, to Heart Cord Junction. I'm so happy to have you here today on my very first ever podcast and really appreciate your time here. So let's begin with, tell us a little bit about yourself and what led you to become a cardiologist and electrophysiologist.
Great. Thank you so much, Alex. First of all, let me congratulate you. This is a fantastic thing to do. I've always felt that we don't provide enough education and talk about the heart in a nice, common way that we can all understand. So this is a great platform. Thank you for inviting me. So yes, I'm a cardiologist and I specialize in the electrics of the heart, also known as an electrophysiologist. I am a Malaysian by birth and I did my medical school training in the UK. My parents believed that the UK sort of education system was the way forward. But it was an invaluable experience because having worked in different countries, different medical systems, and then using it to my advantage of trying to figure out how best to connect to patients, because patients from every walk of life has a different story to tell. And I think having worked in different environments was very useful for that. So after training in med school in the UK, I moved back to Australia, did my training here in cardiology, and then went off overseas to do more specialization. So I was fortunate to be in Italy for about 18 months, and that was a great experience doing research. And then I went off to Canada to finish off my electrophysiology training, and then returned back to Australia in 2016, where I worked as a consultant cardiologist up in Cairns, and then only moved to the Gold Coast about 8 months ago.
Wow. And you specialize in electrophysiology.
I do.
So explain to the audience, what is an electrophysiologist and how is that different from a normal cardiologist?
Well, the easiest way to think about it, I guess, is that if we treat our hearts like a house, so the walls and the windows are just the same way that the muscle and the valves are similar. Then you have the plumbing, which is the blood vessels, and then you have the electrical circuits, and that's what I do. So I basically look after the electrical concept of how the heart works in your body, and when things go wrong, we try to fix them for you and try to basically spot weld things so that things function smoothly.
Right. And so we all want to be in sinus rhythm with a beautiful regular heart rate, and that's that lub-dub sound. So what is the most common arrhythmia that's out there?
I suppose the most common arrhythmia is the arrhythmia that happens as we all age, and that's atrial fibrillation. So you must have heard it's one of the most, as we said, common because as we get older, our heart changes shape and size, and unfortunately, the metronome of the heart does unfortunately get vulnerable as we get older too, and as a consequence, people do develop this irregular heartbeat that can be quite debilitating for some, and it's one of those things because it's going to happen to the best of us. We need to do all we can to try to manage it and try to delay that onset as best as we can too.
So who's at most risk of atrial fibrillation then? Is there a specific cohort?
There certainly is. Like, as we can imagine, the heart being an intimate organ, it's very influenced by the environment and influenced by how we treat ourselves. So one thing we do know is that if we put ourselves at risk of developing structural heart abnormalities, so if we don't look after ourselves when it comes to blood pressure control, eating well, obesity, being unhealthy in terms of not exercising enough, all these things have negative impacts on the heart, and those people are at highest risk of developing atrial fibrillation.
So you say obesity and that it's linked with the atrial fibrillation. Why is that? Is that because of the stretch in that cardiac muscle?
It is. I mean, the best way I can think about it is that if I put on a backpack that had 20 kilos of stones in it and I started to run up a hill, my heart is going to be working harder to move that extra 20 kilos with me.
Yeah.
That strain and stress causes back pressure, and the back pressure causes the heart to dilate. And when it starts dilating, that's when the function also becomes a little bit impaired.
Yeah.
And when I say the function, in this context, I'm talking about the electrical function of the heart. And that's a lot of the time is why atrial fibrillation starts sooner than anticipated.
So can you explain in more depth for us all to understand, how's the electrical conduction of AF different to, for example, sinus rhythm? Where does it originate from?
That's a really good question. So one thing about the electrical part of the heart that I got so excited with was I've always been interested in electricity. I think as a child, I remember being told the story that someone got struck by lightning once and they got magic powers because of it. And obviously that's a myth. But one thing is true is that the heart is a beating organ. It beats 4 billion times in your lifetime. It never needs recharging. And that's because of that special node called the sinus node. It's this specialized group of cells that have evolved over millions of years to basically be a constant driver, a little bit like the composer of an orchestral band. You know, that sinus node is going to keep everything in track. It tells the drummer when to drum. It tells the violinist when to play. The problem with atrial fibrillation is that composer is no longer doing his job. And rather than a nice solid rhythm that's controlled and regular, and that responds to when you're running or responds to when you're sleeping, this is now it's like a popcorn being microwaved in the oven. Things are popping all over the place, and rather than a controlled musical symphony orchestra, you have a drummer and a violinist that's completely out of tune with each other.
Yeah, wow.
And that's what atrial fibrillation is.
Yeah. And I've always described it like the SA node's the boss. You should only ever have one boss.
That's right.
And then
that's
with
right.
atrial fibrillation, all these other little foci sort of go, I want to be the boss, I want to be the boss. Let me send that signal.
Exactly. It's like those naughty kids in the schoolroom. When the teacher's away, they start playing up and acting up, and the whole room gets messy. And that's sort of what's happening with atrial
therefore,
fibrillation.
how does somebody diagnose themselves that they've even got atrial fibrillation? I've always taught clients that the best way is just to feel your radial pulse, that when you're watching telly, you're nice and relaxed, just get used to feeling that radial pulse. Is it regular? Is it irregular? Is it a strong pulse? Is it a weak pulse? But just start getting used to having that feeling of where your pulse is and what does it feel like.
That's so true. It's such a simple thing to do. And like you said, we don't generally feel our hearts. And so therefore, when we don't feel it, we don't sometimes think we need to look after it or we don't need to monitor it. But like you said, nowadays it's quite a useful thing to sometimes sit down and, as you said, listen to your heart and feel what's it doing. I have to admit that nowadays with technology, you have wearable devices that could tell you what your heart rate's doing. And just when people exercise, for example, they do also need to know how the heart's responding. So measuring your heart rate is a very useful thing to do beyond just searching for atrial fibrillation.
Yeah.
And you're right that there's a huge cohort of patients where they're getting atrial fibrillation but don't recognize it because they've never had it before, for example. And paying attention to those symptoms is sometimes a useful thing to do. The tough thing, though, is differentiating what could be normal from what could be abnormal. And my tip at the end of the day is if you feel, when you're not feeling anxious, like you say, you're relaxing and you feel your heart jumping around, it shouldn't really be doing that. Or if your activities have been limited significantly, something you used to be able to do quite easily and you can't do it anymore, these are sort of little signs that maybe something is wrong and maybe you should get your heart reassessed.
Yeah, because a lot of them have the symptoms of, I'm so fatigued, I can't walk that hill like I used to, and I'm so short of breath on minimal exertion. Are those some of the signs and symptoms of having AF?
Spot on. It's the tough thing, as you said, is everybody reacts differently to atrial fibrillation. I have some patients where they can continue their daily living without noticing it at all, and some people are so debilitated they can't even boil water because the process of standing up causes their heart to race so much that they cannot function properly. They get dizzy, concentration drops, productivity drops, all the sort of things that you imagine living life, fully, you cannot do anymore. And it's watching out for those symptoms.
So are one of the symptoms palpitations? Tell me, what's a palpitation? Is that linked to AF, or can it be another arrhythmia?
So it's one of those difficult symptoms to try to dissect. As you just said, it could be normal. You could be, for example, if I ran for a bus and my heart starts to beat faster, the minute I stop running, I might still feel palpitations because my heart is beating faster. Or if I had too much coffee, those sort of sensations can result in palpitations too. The tough thing is figuring out whether those palpitations are actually normal or abnormal. And most of the time, I ask patients, do you feel palpitations when you don't anticipate it to be there? For example, waking up in the morning, you shouldn't get palpitations, or sitting down watching the TV and relaxing, you shouldn't get palpitations then. The other good marker too is whether or not you're getting any other symptoms with the palpitations. Are you feeling dizzy, for example? Do you feel like you might faint? Those sort of things might imply that your palpitations could be due to an arrhythmia rather than your heart just beating faster because it's being stimulated to do so.
And is there any connection between thyroid function or even dementia and AF? Can you explain that?
Yes, I think we just started off by saying how the heart is so involved in most things that our body does. And the thyroid, as you know, being a metabolic organ, I guess, that produces a very important hormone that helps us maintain a good metabolic rate, does affect the heart significantly. And sometimes atrial fibrillation is the first sign that your thyroid might be overactive. So very much so there's a good link. And more importantly, treating that overactive thyroid could obviously reduce your atrial fibrillation risk. So it is part of our workup. When we see someone with atrial fibrillation, we should always check the thyroid function because that's an easy thing to reverse and treat. And like you said, though, we are learning so much about how the heart is intimately related to the brain. And obviously blood flow is an important aspect of maintaining any healthy organ. And if we're going into atrial fibrillation, we've realized that sometimes that our brains might not be getting perfused enough. There could be a bit of fibrosis and inflammation related to that lack of blood flow to the brain. And these things can actually result in worsening brain function and has linked to dementia as a result.
Yeah, wow, interesting.
Yes,
Isn't it?
yeah.
So if somebody has and feels like they've got an irregular heart rate, what's a diagnostic and where do they go? To the GP? Can they go to a cardiologist? They need to get referred. How does that work?
So I think first things first is to have that good relationship with your GP. I think if you have any concerns, go see your GP. A simple test like an ECG, which, as you know, is just a recording of your heartbeat. It's painless, it's cheap, and it's a very good screening tool to see whether you are developing atrial fibrillation. And doing the ECG itself will also help you or help the doctor decide whether there is a structural problem with your heart, because if you have a structural problem, your risk of developing atrial fibrillation is a lot higher as well. So I think the first port of call would be to see your GP and then obviously get referred accordingly.
Lovely. And what are the three different types? I know there's three different types of AF, your paroxysmal, your persistent AF, and then your chronic AF. Can you explain what those three are?
Yes, most certainly. There are ways to describe, I suppose, the chronicity of atrial fibrillation. It helps us as clinicians treat patients depending on how often they're getting the atrial fibrillation. And also the natural history of this condition, like we said, is that it's as we get older, it's more highly likely to develop, and it usually goes through that transition phase of being paroxysmal first, so coming and going, being triggered by certain things, but most of the time, hopefully, resolving itself. But as we said, the natural history is that it begets more atrial fibrillation. So it goes from a paroxysmal state to something a bit more persistent. And at some stage, it could become permanent. And in essence, though, when we talk about permanent atrial fibrillation, it's also partly how we're treating it. In other words, we could treat atrial fibrillation by trying to control its rhythm, so trying to put people back into normal rhythm, but at the same time knowing full well that we are in that inevitable cycle of aging, that some people will then accept the atrial fibrillation, and then it can then be called permanent. So in other words, it's not just the stages of progression, it's also how we treat it. So if we're accepting it and saying, hey, look, maybe the atrial fibrillation is now your new normal, then that becomes also called permanent atrial fibrillation.
And really, treatment, the earlier the better, isn't it? Because the longer somebody is in AF, the more permanent it can become and the more stubborn it can be to not revert back to sinus rhythm.
That is so true. And we've changed our thinking with that over the years as well. In the past, it used to be, let's just try simple management first to try to keep people in rhythm, so treating lifestyle factors or using medications. But nowadays, we've realized that the earlier we attack, the more likely we should be able to try to slow down that process of degeneration, I guess. And so the advice now is that if you wanted to get treatment for atrial fibrillation, we should treat it early rather than miss the boat, in essence, and then accept it as a result.
Because the first line of treatment is really medications, isn't it? We control the rate, we control the rhythm, and we give anticoagulation.
That's right.
Is that still the same? Is that the first line of treatment still?
It is in most places, just sometimes down to availability of what can be used for treatment. But like you said, for me, the biggest thing with atrial fibrillation is not so much the rhythm. As we do know, yes, we like normal rhythm, but the risk we worry about most is, as you said, the risk of a clot forming in your heart. So think of your heart like a sac, which is what it is, and when you're fibrillating, the heart's not pumping effectively. Stale blood can clot. If a clot forms in your heart and flies out and ends up in places it's not meant to, for example, the brain, you can get a stroke. So beyond anything else that we treat when we treat atrial fibrillation is we need to mitigate that stroke risk. Because when it comes to the arrhythmia itself, although theoretically not dangerous in the sense that your heart won't stop beating because of it, consequences can be bad. And stroke risk is one of them. The other risk is obviously if your heart's racing all the time, it's going to tire and it could weaken your heart muscle as well. So as a result, most patients or most doctors would advise we should be as aggressive as we can to treat it, as long as the aggressive treatment is not going to be worse than the actual condition itself. So in other words, treating the patient as part of the disease process is important. For example, if you were 95 years old and you had your first episode of atrial fibrillation, you might be less likely to want to take this patient for an aggressive treatment that's invasive. Whereas if you were 25 years old, you might treat the atrial fibrillation differently, knowing that that person has most probably another 70 years to live with atrial fibrillation. So I think catering your treatment to each individual is important too.
Yeah.
Yep.
And you did mention the risk of stroke, and it's in that little left atrium, isn't it? You've got this little left atrial appendage.
It is.
And I sort of describe it like a little diverticulitis pocket where when blood is not pooling strongly, it can tend to clot in that little left atrial appendage.
That's right. So we, as human beings, as creatures that are made in such wonderful ways, we still have bits of our bodies where we think maybe we don't really need that bit anymore. But unfortunately, the body doesn't work that way. So like you said, human beings have two appendages in our hearts, both sitting in the top chambers. And these appendages are literally pockets that stale blood can hang around. And when people go into atrial fibrillation, 90% of clots will form in that little pocket. And if that clot flies out, it can cause problems for sure.
And aspirin just does not cut it as an anticoagulation for AF. But what are the other two medications that are really prescribed for AF?
That is right. Aspirin has been mistakenly called a blood thinner because because that's what people think it is, but it doesn't really thin the blood. As you know, aspirin just makes the blood less sticky, so it doesn't clump. When it comes to atrial fibrillation, though, you really want that blood thinned because you don't want those clots to form. In the good old days, the only blood thinner we had was warfarin, which works really well and is still available to this day, and it still should be used for certain circumstances. But nowadays, with technology, and we now have drugs that work just as good as warfarin, but without all the other risks that you get with warfarin. As we know, warfarin is a very small therapeutic window. Each person metabolizes warfarin in a different way, so everybody needs a different dose of warfarin. Whereas with these new drugs called the direct oral anticoagulants, they're proven to just work. You just take a tablet, depending on the type of drug and how often you need to take it, but you just put it in your mouth and it just works. You don't have to worry about interactions. You don't have to worry about what you eat, things like that. So they work really well, and I think a lot of patients, should be thinking about going on a blood thinner if their risk factors put them at risk for it.
Sometimes in cardiac rehab, somebody would be saying chronic AF, but due to financial stresses or lack of remote access to a GP, they wouldn't be on the anticoags like the Xarelto or the apixaban. And the concern that we would have is, you're at risk of clotting at any moment and having a stroke. So the concern of trying to get this person in front of a GP or to get them access to their medication was a strong point for us and a point of concern. But there are many people out there that go, look, I just can't afford these tablets.
Yes, and it's true because it's one of those preventative tablets. So it's sometimes hard to convince someone to take something when they don't feel different when they've taken it. Unlike pain relief, for example, if you have a painful knee, you take a painkiller, the pain goes away, you're more likely to take that painkiller. So when it comes to stroke risk and atrial fibrillation, it's about the education, for sure. And knowing full well that if I take a blood thinner, my risk of getting a stroke becomes the same risk as a young person, I guess, a person with low risk features. And it's all about taking a patient through the concerns and their worries as to why they shouldn't be, or why they would or would not want a blood thinner in the first place. The good thing is that if you do have one or two risk factors for developing a stroke, as you know, these drugs are now heavily subsidized by the PBS. So while I do understand there's a cost associated with it, the costs associated with having a stroke or the disability or how it impacts your life is most probably completely outweighed by, the benefits you get by preventing it.
Absolutely. So let's say we've got persistent AF and medications just don't work. What's the second line of treatment that would be recommended?
So nowadays we do have procedures we can do to try to manage atrial fibrillation. In fact, these procedures, they have evolved over the past 2 decades. They have become very safe, fairly quick, and they're done in what we call laboratories rather than a surgical space. And they're the most powerful thing we can do to try to keep people in normal rhythm. The only issue is that doing it too late in a patient's journey, it might be futile. So there is this huge change of thought or thinking process of how we treat atrial fibrillation. It used to be, as you said, let's be as conservative as we can in the first place. But now we know that if we can attack it early, using the most powerful tool we can, which are procedures such as atrial fibrillation ablation, we should be able to at least keep someone in normal rhythm for even longer than what we used to.
Right. I love it. You're talking atrial fibrillation ablation.
Yes.
Now, there's different types of ablations. Can you explain the 2 commonest ablation techniques?
Of course. So ablation sometimes can confuse patients because it's a term just like the word surgery is. You could do surgery on your gallbladder. You can do surgery on your toes. Ablation is a technique of doing a procedure. And essentially what we're doing with ablation is we're forming little scars on the surface of the heart or in the inner parts of the heart to cause an insulation block. That's the intention. And how we form the scar can be done in different ways. So like you said, historically, ablations were always using thermal energy. So either heating tissue or cooling it to cause that little scar. But nowadays, technology has moved again, and what we're using now is an electric field. And what we've realized with the electric field, it's quicker and much safer than using thermal energy. And that's because the electric field targets heart tissue specifically, and therefore then you don't get unwanted collateral damage to things like your nerves or your smooth muscle that surrounds your gullet or your esophagus, for example. So nowadays, the two methods that we do use ablations for will be still thermal energy. It's still available and it's still good energy, but most of us have adopted these electrical field energies, also called pulse field ablation, which is now offered in a lot of centres throughout Australia. And it's now the first line treatment.
So is that's going to be the first line of treatment versus the pulmonary vein isolation or the radio frequency? That's always been the golden standard.
That's right. So once again, these terms are confusing. So I suppose to put it in context, so the word AF ablation is just more of a blanket term in terms of that we're just doing something to target the atrial fibrillation. But the actual procedure is this concept called pulmonary vein isolation. As we know, the pulmonary veins are the tube structures that bring blood back from our lungs into our heart. It sits in the left atria, and it's historically a very arrhythmogenic part of the heart. In other words, that little muscular sleeve that holds those veins into our heart, they can produce electrical circuits. And what happens 90% of the time is small little circuits form within these veins. They escape into your atria and they short circuit your sinus node, and that's how you go into atrial fibrillation. So the operative treatment, or the procedural treatment as they say, is to go up to those veins and isolate them electrically by doing the ablation. And as we said, there are multiple methods. The thermal energy method is still being used to this day, but most of us have adopted this pulse field ablation method because it's quicker and, most importantly, safer.
So you talk about the pulmonary vein and that 90% of the foci originate from these pulmonary veins. Why is that? Is that because of vagal tone? Is it because of stretch in there? Is it because of inflammation? What's the cause that they majoritively originate from that pulmonary veins?
Great questions. And I think you just mentioned multiple reasons as to why those pulmonary veins can cause problems. So we do know that some patients or some people have the genetics to predispose themselves to developing these arrhythmias. And it could be how our heart formed in our mother's womb. It's a very exquisite structure that has so many nuances that any slight changes in the genetics could cause slight issues. So we do know there's a genetic predisposition for people to develop atrial fibrillation because of additional sparking from these pulmonary veins. But also, like you said, lifestyle factors do cause stretch within the atria. And as the atria stretch, these pulmonary veins stretch too. And these then increases the risk of atrial fibrillation. Yeah. So there is, from all we've said so far about treating atrial fibrillation, using procedures and using medicines, the most important thing is to try to even reduce the risk of atrial fibrillation in the first place. And as they say, prevention way better than the cure. And if we can do things to reduce that atrial stretch, that'll be the best way forward.
And so therefore is the AF ablation going to be the golden standard, or are they still going to work at giving you a cardio version first, and if that doesn't work, then go to the AF ablation?
That's another really good question. Certainly in countries whereby the procedure has become very commonplace and very accessible, most guidelines will recommend that as first therapy nowadays. So, for example, in the United States, whereby the ablation procedure is very accessible, that guidelines there from the Cardiac Society has said we should be ablating these patients first up because it's the most powerful thing we can do. And with the safety profile as it is now, we should be attacking these patients or giving them the best chance to maintain normal rhythm. And that's with the procedure. However, in other countries, and unfortunately Australia is in that group, whereby in the public system, these sort of procedures have a long wait list. So it's very difficult to therefore try to get someone treated with an ablation procedure within the first year of that diagnosis. So as a result, we still use medicines as the first line. Most of us would say that most medications work 50% of the time. The ablation could work 80% of the time. And so ideally, in a perfect world, we should be offering ablations, but because of resources and also down to patients' choice at the end of the day, I think, whether they want something invasive done or whether they want something a bit more gentle, as long as they understand the concepts behind why we're doing certain things.
And so if somebody goes for an AF ablation, what's the likelihood that they need to come back for perhaps a second or even a third ablation?
So one thing I always do tell patients is, unlike an inflamed appendix, for example, a surgeon will go in, chop out the appendix, you won't get appendicitis anymore. Unfortunately, the heart is not the same. We can't chop out your atria. So all we can do is spot weld. So in other words, we're trying to fix something from a distance. As a result, the heart does heal certain bits, and therefore then the scars we formed can heal. So in certain centers, some people would say that the ablation procedure should be considered a 2 or 3 stage procedure, because when these lesions heal, sometimes we have to go back and spot weld them.
So somebody's had an AF ablation. I know it's an overnight stay. What are their discharge medications when they leave?
So for the majority of patients, the aim at the end of the day would be to try to get them off their medications, because a lot of patients, they're young when they suffer with atrial fibrillation, for example, and they're not tolerating the medications. So the aim at the end of the day is to try to get them off these rhythm-controlling medications. However, just like when you go for surgery, for the first few weeks, your body's healing. Same thing with the heart. So it's quite common that when people go for these procedures, most cardiologists will still leave them on the same treatment for the first 2 to 3 months until the heart heals, and then the intention is to take them off these rhythm-controlling medications. The issue, though, is the blood-thinning medication. As we said, I wish I could say that our procedures are curative. The intention is to do the best we can, but they're never curative. So the risk of a clot is still there, and therefore then if your risk is high, even after an ablation, the idea is to still protect yourself and to still consider taking these blood thinners.
Now, there's still a cohort where they have stubborn AF. They've gone through the medications, doesn't work. They've had cardioversions multiple times, doesn't work. They've had an AF ablation, doesn't work. And I know this is a minority, but what's the prognosis of chronic AF on the heart muscle, Kevin?
So we're learning lots about that too. As recently as 10 years ago, people were still saying, maybe we don't need to control the rhythm. As long as the heart rate's controlled, maybe that's good enough. And in essence, if there's a slight truth in that, in the sense that if your heart's not racing, hopefully you don't feel the symptoms and hopefully your heart won't tire. But one thing we do know is that the incoordination of atrial fibrillation could result in a lot more morbidity than we realize. And as you said, unfortunately, although prognostically, you're meant to live as long as you are in atrial fibrillation as you do in sinus rhythm, we know that functionally, you're most probably not going to live to the same level of quality. And that's because your heart is jumping around all the time. And so what we do try to do as best as we can is try to maintain normal rhythm, but knowing full well that it is a problem that gets worse as we age. We also have to accept it sometimes. And what we've tried to do is give people the best quality of life by controlling the heart rate. And that's the main aim if we were to accept atrial fibrillation.
So therefore, to control that heart rate, would you consider in somebody with long-term AF, would you consider a pacemaker implant?
Yeah, that's right. So it is part of the ammunition that we have when it comes to the treatment. It is usually considered the last stage, though. And that's mainly because when we do the pacemaker option of treating atrial fibrillation, the whole idea is actually not really the pacemaker, because as we know, pacemakers are usually there to stop someone from going too slow with their heartbeats. Atrial fibrillation is usually a problem with too fast a heartbeat. But what the pacemaker does is that it provides us a backup way that we can then go ahead and basically cut the natural wiring, if you like, so to do a different sort of an ablation to affect the AV node, which is the node that connects the atria to the ventricles, and by severing it, the heart could be fibrillating, or at least the top chambers are fibrillating, but the important major pump of the heart, which is the bottom chambers, those are no longer fibrillating because it's been severed, and the pacemaker will now take over as the main driver for the heart.
Right. But that's always at last resort.
That's a last resort because there's no going back. I suppose once you cut those ties, you've cut the ties. But having said that, a lot of patients who go through the whole process of trying to manage their atrial fibrillation, and as we said, although our technologies have improved and we're able to maintain rhythm for a bit longer, at the end of the day, the inevitable happens, and therefore there's this last resort that a lot of patients, when they do end up going down that path, they feel a lot better because their heart doesn't race anymore. They just become dependent on a pacemaker.
So the take-home summary is that atrial fibrillation is very common, but we need to act on that treatment as soon as possible, don't we? Because the longer somebody's in AF, the harder it is to revert back to sinus rhythm, isn't it?
That's exactly right. And as we said, the way we used to think about it has changed. And what we do realize is that the ability to diagnose atrial fibrillation has become a bit better with technologies such as your iWatch or your Fitbit that can now measure your heart rate. So if we're able to diagnose it earlier, we should be able to intervene earlier, and that would be the gold standard.
Kevin, I'd like to just go back to the risk factors. So how can somebody manage the risk factors and control their AF?
That's a tough question because there's so many things that affect how we or when we develop atrial fibrillation. But there are definitely a couple of known risk factors, and they're not unusual when it comes to heart health. So the usual aspects of hypertension, diabetes, those sort of things that have a chronic impact on our health overall. But specifically with atrial fibrillation, I suppose the two biggest ones that we're seeing more and more these days are things like sleep apnea and being overweight. And unfortunately, it is such a common thing that we are underdiagnosing nowadays with sleep apnea. And as you know, with sleep apnea, it's our body suffocating itself every night. And as you can imagine, when we're not breathing, our heart's going to be working much, much harder. And we've realized a huge spike in atrial fibrillation as we are diagnosing more and more sleep apnea. And we've got good evidence to show that if you treat the sleep apnea, your atrial fibrillation burden drops. And in certain studies, doing that ablation procedure we talked about is pointless if sleep apnea is still persisting. So it does highlight and underscores how important it is that although we're trying to manage the electrics of the heart still forms a small puzzle in the bigger picture of things, and addressing those bigger pictures are important.
Because that's right. It's the risk factors, isn't it?
It
if
is.
somebody, say, is waking up feeling exhausted and waking up multiple times in the night, that's where they need sleep studies to ascertain whether they've got sleep apnea or not. And also about being overweight. And they can manage that by maybe incorporating some exercise, looking at nutritional needs, looking at portion control. Those are all the things that they can start working on themselves, isn't it?
Exactly. And that should be from day one sort of thing, from the point where you go, is there something wrong with my heart? Am I getting irregular beats? What you need to start doing then is start realizing and start recognizing that, hey, I do need to change things because my heart's trying to tell me something here. I need to listen. And sort of along the same lines that we talked about the sleep apnea and how treating it actually makes ablation procedures more successful, local Australian data has shown that if you are overweight and you lost your body mass by 10% back to a baseline that's considered normal, is as powerful as doing the ablation itself. So in other words, there's a huge link between being overweight and obese and developing atrial fibrillation for sure.
That's incredible.
It
that
is.
it can equal the same as having an AF ablation by losing 10 points off your BMI, is it?
That's right. So if you were overweight to start with, naturally, if you were of normal weight, losing 10% of your body weight most probably would not be so good for you. But if you were overweight to begin with, it definitely has a beneficial effect. And I also want to highlight a couple of other things that we do to ourselves too, which is the stimulants we take, the alcohol we take, the caffeine we take, and also just being dehydrated. That's a stimulant too. So I think there's so many factors that we see that has a huge impact on the heart. And some people do ask me, this atrial fibrillation, is that caused completely by alcohol? And I would say that most probably not caused by the alcohol completely, but alcohol being a stimulant can precipitate atrial fibrillation. And some people are exquisitely sensitive. I've got patients whereby if they have a cake that's been infused with rum, that would set off the atrial fibrillation. So something as simple as that, and identifying those precipitants and avoiding them definitely will be a helpful aspect of management as well.
And it is that stimulant, isn't it? Like coffee is a stimulant.
That's right.
Alcohol is a stimulant. And so just with coffee as well, let's say somebody's had an ablation. What's your guidelines of people that want to drink and have a cup of coffee straight after an ablation?
Well, caffeine has some benefits for the body, as you know. It's got some good benefits for the heart. But when we're talking about the benefits when it comes to an arrhythmia, there's no benefit at all. And so when you do ask a person about their caffeine intake, a lot of the time it's a social thing. A lot of the time it's habit, not so much about the caffeine itself. So if someone enjoys a cup of coffee because it's the time that they catch up with their friends, maybe go on to decaf instead, or maybe reduce the volume or the strength. So there's so many ways around that, but there's definitely a link between caffeine and arrhythmias.
When can somebody return to normal exercise after an ablation? What are your recommendations?
So the good thing about a procedure like an ablation, because technically it's minimally invasive procedures, there's no physical scar on your body. The only issue obviously is allowing the excess site, in other words, the vein that we use to get into the heart, the one that we get access to that's the easiest is the vein in your leg. And naturally, it's in a position whereby if you did too much exercise immediately after, the puncture site we've made is a bit weak, and there's a risk of bleeding as a result. So for most of us, we would say for the first 7 days, avoid doing excessive exercise or too much heavy lifting, but after which the intention is for you to return to a good quality of life. And so from an exercise point of view, because you've taken a week or two off, because you're healing from a groin perspective, maybe when you return, you should do it in a graded sort of way too, just so that your body isn't under so much stress. But the intention is for you to return to full activities within a week or two.
Okay, thank you.
Not at all.
So what do you do and practice for your heart health?
Well, I guess I'll be honest. All of us have vices every now and then that we, for example, yesterday was actually my birthday, so I did have a few extra drinks
Happy
yesterday.
birthday.
I know, thank you. But I think it's about that moderation, isn't it? And realizing that we're never perfect and we're allowed to indulge every now and then. Otherwise, life would not be worth living, in my mind at least. And so I suppose recognizing that we need to change our mindset a lot of the time when it comes to our health and not be afraid of judgment, afraid of what other people would say, and just believing that your health comes first at the end of the day. So for me, it's about the physical side of things, but also the mental side of things. Being able to take a walk with the dogs every evening to clear your mind, to allow the stress levels to drop, because we haven't talked about stress yet and how important stress is when it comes to heart health as well. And there's a relationship between stress, anxiety, and arrhythmias too. And being able to de-stress and being able to, I suppose, sometimes put yourself in a position where there's so much noise and busyness around you that if you don't take time for yourself, then your health will suffer too. So as we said from the beginning, it's all about balancing the physical, the mental, and the spiritual. And I think that's what holistic health is about.
It is, isn't it? It's this real balance between mental, physical, mindfulness. And like you say, there is a relationship between AF and stresses. And I think finding that mindfulness time of whether it's whatever brings you joy, reading a book, going for a walk, listening to music, just
Exactly.
breathing, to allow that mindfulness time and just to be able to listen to the heart and switch off that busy mind that we all lead such busy lives. So I think it is. It's about that work-life balance, isn't it?
It is.
And
It is.
eating good nutrition, sleeping well, doing some exercise, mindfulness, put all that together to create this heart health and healthy mind, body and spirit.
Definitely. And making it fun in the process too, because I suppose if we treated life like a chore and we treated everything we did as an obligation, then we wouldn't be doing it.
Wouldn't be much fun.
That's
would it?
right.
No.
Exactly.
So, in summary, if anyone wants to look you up and connect with you, how do they find you, Kevin?
So I work at both the public hospital as well as the private hospitals here on the Gold Coast. So certainly if we want to come and get some advice or have a discussion, the Gold Coast Heart Centre is where I work from both multiple sites, Gold Coast Private Hospital as well as John Flynn Hospital. But I'm also in the public hospital system too. So a GP can refer to us for access from a cardiovascular side of things.
Thank you so much for coming today. I really, really appreciate your time, and I really appreciate everything you do in this cardiac space. It's incredible, and thank you so much for your time with me today.
Oh, no, thank you. Thank you for having me. It's been a great day.
So if you liked this podcast, please like and subscribe to my podcast, Heartcore Junction. Alternatively, you can also follow me on Instagram. It's heartcore.group. And follow me on Instagram, or otherwise you can also book me for a workplace seminar where I'll come to your workplace and we educate on cardiac disease risk prevention and also the other diagnostics that are available today and blood work that can be done. Again, just look on my website, www.heartcoregroup.com, or email me on info@heartcoregroup.com. Thanks very much for watching, and until another episode, see you soon. Thank you.